Broadcast is now starting. All attendees are in listen-only mode.
Welcome to today's session entitled Aging Positively, Bringing HIV, AIDS into the Aging Services Mainstream. Before we get started, I would like to go over a few items so you know how to participate in today's event. When you joined today's webinar, you selected to join either by phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time, and we will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce John Feather, CEO of Grantmakers in Aging and moderator for today's webinar. John?
Thank you so much, Clara, and thanks to all of you who have joined us for today's conversation with GIA, Aging Positively, bringing HIV and AIDS into the aging services mainstream. As always, we want to thank the John A. Hartford Foundation for their support of this entire webinar series, and we want to extend a special thanks today to our sponsor for this particular webinar, Gilead Sciences. Today, almost half of the people living with HIV are 50 years old or older. Thanks to advances in science and treatment, this is the first generation of people living with HIV to reach this age and above. And this is a hard-fought triumph that should be celebrated. For many of us who work in the field of aging, 50 may not sound particularly old. But part of what we are learning is that getting older and living with HIV brings a new set of unique challenges, many of which we are not ready for. And HIV and AIDS must now be considered as an aging issue. Today we'll talk about how funders and the aging services community can engage a new generation of people getting older while living with HIV. We welcome today's speakers, Nancy Zients, who's the Chief Operating Officer and Chief Program Officer at Jewish Healthcare Foundation in Pittsburgh, Vince Christosimo, who is the Program Director of the Elizabeth Taylor 50 Plus Network at the San Francisco AIDS Foundation, and Dr. Eugenia Siegler, who is a geriatrician and founder of the Aging with HIV program in the Division of Geriatrics and Palliative Medicine at Weill Cornell Medicine in New York City. We welcome all of you. As I mentioned earlier, you will have an opportunity to ask questions at the end of this program. Please just open the question box you find on the right side of your panel, and at any point, and just type in your questions and we'll be answering them later. So Nancy, let's start with you. Tell us a little bit about how the Jewish Healthcare Foundation came to be involved in this issue.
Thanks, John. It's my pleasure to be here today because we're putting together two things that our foundation has long been involved in, and that is both aging and HIV/AIDS. So our foundation was started in 1991, and both of those agendas date back to about that time period. But they date back there separately as two completely separate, siloed agendas that are for no reason other than they grew up organically as being separate agendas. And I'm very excited today to talk about what we've done in our HIV/AIDS agenda, and then to talk about what opportunities we see for incorporating that work into our aging agenda, and importantly, vice versa. So we have been the fiscal agent for Southwestern Pennsylvania since 1992, which basically means we have done a lot of work managing the funds that have gone out to our community agencies. But in addition, our foundation has been very proud to support those opportunities that did not receive state or federal funding over the course of the 25 years or more that we've been involved in HIV/AIDS. And that's been some quality improvement and capacity building, a hospital readmission project, and some needs assessment. I'm joined here today, and I'm really pleased to be joined here today by the person who runs our agenda for the foundation, who's Richard Smith, who's the project director of our HIV/AIDS department, as well as members of his staff. We have an excellent staff. We think they are the best in the state, and I'll put them up against any across the country on any given day. Next slide. The role the Jewish Healthcare Foundation has played for the first 12 boxes that you see there are fairly traditional roles of contracting and invoicing, but we've gone well beyond that through the creativity of the staff to really figure out ways to engage our community and provide unique technical support and create regional collaboratives that have gone well beyond the mandate of what a fiscal agent can do or should be doing if they were just going strictly by the letter of the law. Next slide. What you see here are a list of a variety of services that are funded in the southwestern Pennsylvania area. And what's interesting is these are the services for persons with HIV/AIDS. And I defy any of us to take a look at those services and say, well, aren't those things we should be doing for seniors as well? Because that is a strong, robust basket of services that persons with chronic illness or living with changes in condition over time and place will need. So that's an HIV/AIDS list, but to me it also looks like an aging list. I don't see that much of a distinction. Next slide. But the next few items I want to touch upon are just a few examples of the creativity of the staff at Jewish Healthcare Foundation. And again, I'm talking about Richard and his team, not my team, not for lack of trying or being invited in. But we have really taken a lot of our principles about learning together as a community, and we have brought them together for the HIV/AIDS community in southwestern Pennsylvania and now across the entire state. So we conduct Ryan White learning sessions, next slide, and the learning session approach is about networking, education, and then reflecting on how we can act together as organizations that you may have multiple organizations that are serving the same client, and traditionally that would have been separate interactions between those clients and those agencies. And through these collaboratives, we're creating awareness of a variety of services and a variety of opportunities to make more and better services available without redundancy and without making clients go crazy having to go from one agency to another to get their needs met. Next slide. One of the other unique opportunities that we've had, and I'm glad to have a colleague from San Francisco on the line as well, is we are one of the only communities that has decided that we are going to invest our resources and our talents in trying to be an AIDS-free community. And there's an AIDS-free Allegheny County initiative which has been directed by our team, which we're proud to say now may go statewide, as we really look to a future, as John said, without new infections and the opportunity for us to create a new normal where HIV/AIDS is a managed chronic disease. Next slide. One of the major opportunities to develop an AIDS-free community started with work that was done with the Minority AIDS Initiative, the MAI Grant Initiative, where this was an opportunity to look at people who are lost to care. So these are people that we know are out there with HIV/AIDS, but who may no longer be receiving services. They may have received services once, twice, or not at all, and yet they are out there at risk potentially to themselves and others. And how can we create an environment where they feel safe and welcome to come in for care, where they can be identified early and enrolled in programs and services that meet their needs? And very often what the team found was very often the needs of the individuals were not being met because the service systems were not being sensitive to their needs and didn't have a cultural orientation towards outreach or service that met the needs of the population. And I say that again because I feel that is also true when we talk about seniors. It's all about how do we sensitize the population that is providing service to the population that is receiving service. Next slide. And some of the strategies that were used by the team for the Minority AIDS Initiative were unique strategies for client outreach, risk assessment and reduction, motivational interviewing, finding out what was the most important item for the client that would engage them and have them recognize why returning to treatment and staying in treatment was in their best interest, the best interest of their family, and the best interest of their community. And to go along with that were what we consider to be some necessary elements of process improvement, data management, and then again, statewide collaboration and peer learning, because none of this is good if we keep it to ourselves. This is about shared learning and joint opportunities to improve upon strategies that others have brought before them. So this brings me, next slide, to where we are today, which is really looking at aging and HIV and what are our opportunities and what are our gaps. and why haven't we brought these two agendas together in the past, and what are the opportunities to do that in the future? So I think one of the reasons why we have not brought these services together, and the we there is a general we, not just the Jewish Healthcare Foundation, has been this lack of awareness, that tipping point that we are reaching now, where 50% of the population with HIV/AIDS will be over the age of 50 and then beyond. And now when people hear that, they go, it didn't occur to me. It didn't occur to me that those persons that we had considered having a death sentence in the past are now living with a chronic condition, and they are now entering the aging service system opportunities. What are we going to do about that? And if we didn't know about it as individuals or members of the community, we also didn't know about it when we were providing training to the vast majority of providers who are out there who never took a class in medical school, nursing school, pharmacy school that had to do with HIV and aging, and didn't have a chance to look at those coexisting conditions or those coexisting opportunities. And the third becomes service coordination. And I know that many of us have been challenged over the course of our careers to realize that somebody was in the mental health system or the physical health system, and nary the twain shall meet. The same is true with the aging system, the HIV system, the mental health system, the social service system. Those exist as silos traditionally in our county and state systems, and now the question is, how do we open up that Pandora's box and make sure that we can coordinate the services in the way that is in the best interest fiscally, but also, importantly, the best interest of the persons with HIV/AIDS. Next slide. So when we consider looking at HIV/AIDS and aging through a new lens, it's about looking at, that is our aging agenda in a nutshell, although it's about how do we keep people living well and safely in the community, how do we keep seniors well and safe in the community regardless of their income and regardless of how their condition might change over time. I look at that and I think that's perfectly applicable for somebody who has an HIV/AIDS diagnosis. And the question becomes, how do we look at these various systems and ask the questions, how is this the same or how is this different for somebody with HIV/AIDS? And I'm not going to go into detail on geriatric-friendly healthcare because I know Eugenia is going to focus on that in a little bit. But I think that as we look at these topics, whether that is housing in an institutional setting or housing in a community setting or independent living, we can ask those questions. How is it different? How is caregiving different for persons with different family setups than they are for what is considered to be a family that was raising their own caregivers within their four walls for their whole lives? What does end-of-life planning look like? What do the legal and financial aspects look like for persons with HIV/AIDS? And again, very importantly, what does provider training look like? And an important part of our agenda is looking at persons with dementia. And that is not only an important issue for persons with HIV/AIDS, but it's an important issue for any family facing aging within their family and considering how does that look differently, how does that perhaps manifest it differently in the community. So in conclusion, my goal would be for us to look at HIV and aging and say to ourselves, the time is now. We have finally reached that threshold. Richard and I have talked about this for 8 years. When is it time to commingle some of these programs? We believe that the time is now. The data are there, the statistics are there, and this is no longer about a special population. This is just about special considerations for the general aging population. And with that, I'm going to turn it back over to John.
Well, thank you so much, Nancy. That's a wonderful introduction to this important topic. And now we're going to move on to someone who has been deeply involved in the actual care of individuals who are both HIV and AIDS clients and also are older. So Dr. Siegler, why don't you take it from here?
Thank you, John. Next slide. Nancy's given me a great introduction, and I will be focusing a bit on the clinical side, but I want to remind our listeners that in addition to what goes on in the clinic, that social needs are a huge area that has to be addressed. It took a long time for the research agenda to get beyond the demographics, that is the recognition of how many people are aging with HIV, to examining what does it mean to age with HIV, and that focus was largely on medical problems, comorbidities, multimorbidity, and the medical care needed to meet their needs. With a bit more of a geriatric approach, we are looking at aging-related syndromes, how to keep people well in the community, and what the long-term care needs are. So it is indeed care across the continuum, and we're trying to understand how to provide that care. Next slide, please. It helps to think a little bit about what geriatrics does. Although I think everyone has now heard of a geriatrician, the major geriatric societies, the British and American Geriatric Society, recognize that people don't understand what geriatricians do, and they came up with a concept called the 5 M's. That is, geriatricians look at individuals and concentrate on 5 main things, and that is mind, medications, multimorbidity or multi-complexity, mobility, and what matters most. So it isn't that they ignore medical problems or a treatment of specific illnesses, but those things are just one part of a host of factors that have to be taken into account as we try to understand what will work best for the patient. Next slide, please. In the first year or so of patients that we saw who were aging with HIV, we found that many people living with HIV share a number of concerns, and in the case of those I was following, the commonest worry was cognition. You know, is there something wrong with my memory? Or in this case, or in other cases where their physicians were concerned about their memory, even if they were not. But there were a variety of other issues, a desire for more services, medical problems, function and gait, smoking cessation, as you can see, a number of problems, and a few where we can discuss chemical dependency. One of the points that we often emphasize is that aging does not make any problem go away. Aging just adds aging to any problem that was pre-existing, and so we talk about everything. Next slide, please. We have had an HIV and aging program for a number of years. It started in 2012 just with joint conferences with HIV provider, giving grand rounds to the geriatrics division about the changing demographics, and then with geriatricians and geriatric social workers coming to the HIV practice and talking about geriatric issues. We were able to get Samuel's Foundation support in 2015 to inaugurate our program, and that program included both geriatric consultation embedded 1/2 day a week in the HIV clinic in Center for Special Studies here at Weill Cornell, but we also had a number of community programs, and we reached out to some of the community agencies to try to have collaborative efforts. One of our challenges is how we sustain those community linkages. Next slide, please. This is just a picture of the kinds of topics that we discuss in the clinic when we do a comprehensive geriatric assessment. Those of you who work in the clinical setting may recognize a screen from Epic, and we've been able to embed our assessment within Epic so that I can, or my colleague, Dr. Del Carmen, can click on buttons, and as opposed to write things out longhand, and that assessment will appear in our note. To the left is a description of the things that we look at, and we try to be as comprehensive as we can with history, physical screens for depression, anxiety, and frailty, questions about pain and quality of life, and cognitive assessment as well. Next slide. But one of the key points is we don't quite yet know how to adapt geriatrics to HIV care. We found, if you can advance the slide a little bit, we found that even though we were very popular, only about 1/3 of our recommendations that first year were actually completed, and we've grown to recognize that you have to translate a geriatric perspective into a true comprehensive assessment of older people who have HIV. Next slide, please. And similarly, once you have figured out what kind of assessment do people with HIV need, what are the recommendations that you can make? What's feasible and what's useful? How do you translate those observations into real action? Next slide, please. So there are so many areas that we need to explore and study and test, and again, given my frame of reference, which is the clinic, even the clinic itself has a number of challenges. How do we do primary care in a limited amount of time? Who's going to do primary care? Because the workforce changes would suggest that HIV specialists will not be able to meet all the primary care needs of people aging with HIV. So who's going to do primary care? Who's going to do HIV care? How do we fold in the aging concerns? What do you do when there's limited money and access? And how is all that put in the clinic? In addition, the silos were mentioned in Nancy's talk, and yes, from our point of view, everything that's outside the clinic is siloed. So the subspecialty care is only occasionally directly linked to the clinic, and geriatric and HIV social services are themselves siloed, and we have found that people who are experts in the HIV services network need a lot of training in geriatric social services. Next slide. So as we've tried to understand, what are the questions that we need to answer, what are the things we need to think about, I was asked to sort of put together something on best practices, and there are no best practices. We're still really trying to figure our way, and in so many different areas. But these are the questions and the unresolved practices that we have to just begin to sort out. And who is going to be sent to a geriatrician or be given a geriatric assessment? Is it by age? Is it by function? How are we going to assess them? Which tools will we use? How much time do we have? What happens when we find something? Where will they be referred? Where is this going to be located? Is it going to be embedded? Is it going to be in a geriatric clinic? Should there be gerontologic nurse practitioners or social workers doing most of the staffing, or pharmacists? What is the focus? Is it going to be in prevention of functional or cognitive decline, management of diseases, working to improve social supports? What are the criteria for success? What outcomes are we measuring? Is financial viability ever going to be a legitimate outcome here, or will we always be dependent upon foundations and insurers to underwrite these programs? Finally, what are our linkages? What is not only our relationship to primary care, but linkages to community organizations, and how are we going to prepare for long-term care, both within the community and outside the community? So these are all areas that foundation support can help determine. Next slide, please. So I have some references here for further reading, and again, I'll be happy to answer questions, but I'm going to send it back to John, and hope to be able to communicate with others at the end of the talk about the issues that are of interest to you.
Well, thank you so much, Dr. Siegler. And just a reminder to everyone that we will be making both the slides as well as the audio available to everyone who registered for this program, and it'll also be available for anyone else who has an interest in seeing it later. So all of these things will be available to you. Now we turn from that great presentation on some of the clinical and healthcare aspects of caring for older people with HIV and AIDS. And now we'll move to Vince, who's going to talk about the on-the-ground social and community-based services that they are finding are important in serving this population. Vince?
Good morning, everybody. I'm really excited and honored to be part of this presentation this morning. In addition to what's been said, I've also been living with HIV for 32 years with an AIDS diagnosis since 1995. So I am of the population as well as working to serve them. Next slide. So we have a lot of issues when you get to this point. Number one is housing. There is a popular saying, housing is healthcare. For people living with HIV, a unique argument we found from working with other senior populations is that if you keep someone housed, they're likely to adhere to their medication. They're more likely to stay virally suppressed. They're easier to reach. And this seems to be an issue across the country where people who are aging with HIV, housing is probably the number one issue for them. Next slide. So like I said, we have a lot of needs. I could probably spend like the next 20 minutes going over that, but in San Francisco, 67% of people with HIV are over the age of 50. There's higher levels of stigma and isolation. There's higher levels of mental health. There's post-traumatic stress. There's multiple traumas. Many people have spent a number of their adult life in isolation, only to reemerge to find that their friends or new friends that they're meeting are dying of older age. There's the complications of having a chronic disease. There was a study that was done in the early 2000s that found that people who were HIV positive and in their 50s had 3 times the comorbidities and mental health conditions of those who are not positive in their 70s. Complicated treatment regimens, polypharmacy is a huge thing within our networks. What are people taking? What are their interactions? Having to navigate the system, navigating systems of care. It's been challenging. In addition, there's training of staff, which I think Nancy had also mentioned. But, you know, a lot of staff in HIV, they have strong views on ageism. And so I often hear from the guys in 50 plus that, you know, it's like these agencies keep hiring these 24-year-olds to serve us, and they're not really sure, but they're the most sensitive. Their HIV doctors tend to attribute everything to either HIV or aging, but they don't have the expertise in aging to know or really be able to kind of unpack what that means. And I'm often finding that because some of the cognitive issues that people have, you often have to repeat things several times to for them to get the message. The other this designation of HIV and aging, there also is the term long-term survivors. It's not a term that applies to everyone. In San Francisco, we include positive and negative. Not all locations do that. People of color here in the Bay Area don't seem to identify with the long-term survivor label. They think you know, they have been surviving life, and so that's different. Next slide. So these are, like when I took over the program, these were the main issues. Didn't plan to live, didn't plan financially. They live on fixed income. There's an issue with people who went on private disability in their late 30s or 40s, have lived on, and had, if they had a decent career, they lived on a fairly high income. And when they turn 65, they age out. And because they haven't contributed to Social Security, they could lose up to 75% of their income. Food insecurity is a huge thing within our network. We find that because people pay 70 to 90% of their income to rent, they often skip 2 meals a day. And other issues are transgender health. The transgender population has its own unique set of issues that they present, and so those things need to be taken into consideration. Let's see, next slide. So our Elizabeth Taylor 50 Plus network, we've been around since 2013, and we promote the physical, mental, and emotional well-being and self-efficacy of gay, bi, and trans men over the age of 50, regardless of HIV status. So that includes positive and negative. And we provide resource navigation, social support, educational groups, and volunteer opportunities. We also don't hold tight to the 50 plus. If someone shows up and they identify with the population, you know, we don't do an ID check. Next slide. So let's see. So these are, there are 5 components that we do: social support, volunteer, giving back to the community, resource navigation, and then we do education, advocacy, and community mobilization. Next slide. So under social support, so we do, I try to do things that kind of focus on what people may have done earlier. And so we've had great success bringing people into different neighborhoods to kind of rediscover San Francisco. We have a Wednesday night dinner in support discussion where we have an average of 65 to 75 people showing up. We do something called New Traditions, where we spend Thanksgiving, the night before Thanksgiving, together, and on Christmas Eve we go to dinner and we attend a concert with the San Francisco Gay Men's Chorus, which many of our members have been a part of. Next slide. So Solstice Sundays is something we've recently introduced, where we go into one of the neighborhoods, we invite actually the community, and we invite providers to come and mingle so that people can start to see. People tell me it has the feel of old San Francisco, and we usually get 60 to 80 people at this event. But it's a time that if we know someone has an issue, we can actually connect them to someone who might be able to help them. Next slide. Volunteers. So a huge part of giving people something meaningful to do is getting them to volunteer. So we have a program called the Bridgman, which is intergenerational, multiple different ages, but we look at civic and social engagement, like where can we send people, who can we team up with, who can we collaborate, and these are projects that are meant to give back to the community and to kind of just make people feel like they're worthwhile. Next slide. And resource navigation. This is a little harder. Many of the folks in 50 plus, like, they don't see themselves as seniors, which is challenging when we have a lot of resources in San Francisco, but how do you get them to access that if they're not seeing themselves in that way? So there you see it. We've helped people with housing. Health insurance is a huge thing. Understanding like what's available, how do you choose a doctor, how to navigate different systems. We have a shortage of geriatric providers that we can refer people to, but we work very closely with something called the Golden Compass, which is part of the Ward 86 at San Francisco General. And let's see, we work very closely with AIDS Legal Referral Panel, which handles a number of things: benefits, end of life, paperwork, things like that. And we've recently, in the last 3 or 4 years, looked at how to get people to go back to work. If your viral load is suppressed and you are, how do you do that? And what do you need to think about? For some people, it takes quite a bit of work. It's its own kind of hand-holding and case management. Next slide. And then we do education and advocacy. So we try to figure out what if you can see this slide, it's a picture of some of our members, one of our members in particular, at a climate change, like teaching people that there's more to life than HIV. How do you get out? Trying to network with like housing groups so that when we go to City Hall or we go somewhere, it's just not just us. But we also have something called the HIV Advocacy Network within San Francisco AIDS Foundation, and we've plugged quite a few members into that. We take them to Sacramento, we've taken them to DC, where they get to talk about their lives and advocate for themselves. Next slide. So I like to include this slide in my presentations because this is something I did early on. I think this is from 2015. and we're doing rapid water, and if there was another slide, you would see half the people had fallen off the boat. And so I tell people, this is where we stand. Do you want to face the future in fear and uncertainty, or are you excited to see what if you're going to make it to shore and what is needed? You need to assess where people are and then kind of have a plan of where do you want to be, in the time that you have. And so can we go to the next slide? So we are in the process of kind of reconfiguring the program after 5 years. We find that things need to be freshened up a bit. In planning for the future, one of the things that I know people often, when they retire, they envision living in someplace else. Like San Francisco is very expensive, but thinking things like, what am I going to do about my health care? I was living in Bangkok and found I had to leave because having lived with HIV for over 25 years, they couldn't, and having been on medications that had not been available yet in the country, the option of staying in Thailand was not there for me because they couldn't treat me. So these are things that we've learned to think about in planning. So we are, I think this is my last slide, but we're in the process of conducting a comprehensive planning process that will result in a model of case management for people over the age of 50 who are living with HIV. We intend to do this through collaboration. We will continue to support policy and funding initiatives at federal, state, and local levels. This is something that does get our group going to improve cultural inclusiveness and competency. So connecting aging providers and HIV providers, also building their capacity for them to address the needs of the population. And let's see, I already said and again, increasing access to mental health. It's been very difficult. Often what I've observed and what has been reported is that the HIV agencies, they have not changed their services as people aged. And so what needs to happen? How do people's needs change as they age? And I think the next slide. Okay, that's it. So anyway, thank you. I hope I wasn't talking too fast, but I'll turn it back over to John.
Well, thanks very much, Vince. That was great. I mean, all these presentations are very useful and raise different issues, and we have a lot of questions that you have submitted. But please continue to open the question box and write in your questions. We'll try to get to as many as we can. But the first question is about those who are homebound and may have housing now, but they no longer really can perform the normal activities of daily living. And to what degree are you seeing this, and how do you provide services to them? I think Dr. Siegler or Vince, I don't know who would be the best to answer this, but I'll let you move forward.
I'll start.
Okay.
Yeah, you go ahead. You go ahead. That's fine. Who's going to start?
Go ahead, Vince.
This is Vince. I have been a member of the San Francisco Mayor's Long-Term Care Council, and so one of the first things I did was I sought out partners, and I found out there's a group called Homebridge here. They have 142 people who, on their caseload, who are HIV positive and homebound, and so I've tried to get people to identify people that they may, who they know, who they feel comfortable with, who might be able to come into their homes and take care of them. Creating a buddy program, Shanti, which is very, has a famous track record here in San Francisco, replicating that model, but for the aging population, where people would provide emotional and practical support in their homes. This is where having an intergenerational program is really helpful. I often find that sometimes the 50-plus guys, while they may be well-intentioned, they're not always well-suited to provide the kind of support that's needed, because it can be very triggering, or someone has issues like hoarding, going to someone's house. So it takes some training, and it also takes some added support. And how are you going to support those folks? Back to Eugenia.
Yeah, thank you. A couple of comments. Obviously, that they're homebound medically can still mean that people come to clinic, but what I would say that within the Aging Services Network, there are similar buddy programs, and I have referred people to buddy programs both at GMHC, an HIV services organization, and another local organization that has served elderly, DeRote, here in New York City. So that one of the things is to, again, look and see what's available in both networks and try to find ways that those networks coordinate with each other. The other point I'll bring up, and again, it's would be a wonderful area for foundations to explore, is that there are well-established programs for people who are who have ADL and IDL impairments, but who we are able to keep in the community. PACE programs, Program for All-Inclusive Care of the Elderly, is one. Villages is another. These have been clear. These are clearly effective programs for older people, and there's a great opportunity to say what has to be tweaked, what has to be adjusted so that they can be implemented for people who are aging with HIV. So I think that it's a great question, and I think that the real response to it is starting all over again and seeing what kinds of programs can we create that combine the medical and the psychosocial and housing care for these individuals. And there is no reason to start from the very beginning. See what seems to be effective in the geriatric literature, but find out what other special needs have to be incorporated, and try it out.
This is Nancy, John. If I could add also that many states, we're well over 20 now, have implemented managed long-term services and supports programs under Medicaid and for duly eligible individuals to allow them to stay in the community if they need skilled services, but to elect not to go to an institution. So when we were implementing and marketing the program within Pennsylvania, we were sure to reach out to the AIDS Services Network to make sure that persons with HIV/AIDS also knew that this could be an option for them if they qualified under their skilled benefit and Medicaid. So in addition to PACE models, there are other opportunities to look at the public programs and say, why couldn't this work for somebody with an HIV/AIDS diagnosis?
Thank you, Nancy, and I thank you all. But Nancy, let's stay with you because we have several questions about reimbursement. Obviously, the levels of reimbursement for any of these services, geriatrics in general, are not as strong as they need to be. But what are you finding are some other ways that you can try to bring these two things together, and where do foundations fit into that?
Well, we spend a lot of our time, in addition to focusing on issues around institutional care, which is, especially under CMS, it is agnostic as to what a person's diagnosis is. When we look at home and community-based services, there are plenty of opportunities within the communities, within the Administration on Aging Services, whether that is senior centers, whether those are university-based programs that are helping individuals engage in lifelong learning, or outdoor programs or recreation programs, exercise programs like Silver Sneakers. A lot of those programs that have traditionally been in the HIV/AIDS world, I think it goes back to that original aha moment of, do we have the awareness that now that somebody has reached the age of 50, or some cases 55, depending on the program, they're now eligible for these services that up until now they would have never considered. And they can cross that line and walk into that center or call a social worker and say, you know what, I'm interested in something that can help me with my opportunity to age well in the community. Part of that is there's recognition on both sides that needs to happen. One is the recognition that there are persons with HIV/AIDS over the age of 50, and then I'm 59 years old. When you said we're considering people over the age of 50 old, I aged right in front of your face, John. I mean, it was just people who are over the age of 50 don't consider themselves to be seniors. I think the idea of what a senior is always somebody older than you. So I think getting people to understand that these are now services that exist, and there's no reason why they couldn't cross that line and go and ask for that service, whether it's a SNAP benefit for seniors or others. If they meet the eligibility criteria, they can jump out from one silo and get into a more mainstream program.
Nancy, this is Vince. that has been the biggest hurdle to get people to access traditional senior services or mainstream senior services, that they don't see themselves as seniors, and they're afraid they're going to be treated poorly by these providers. And so we're constantly working on that.
Yeah, thank you for all those responses. Dr. Stigley, you mentioned, and I think Nancy did, the cultural competency training, and particularly around HIV issues and AIDS issues, but also the LGBT aspect of this. And, you know, we're now seeing, of course, an additional group of people who are often women of color in the southern United States, is now the fastest growing new infection group. So we have lots of complexity in all this. Do any of you know of good cultural competence references or programs that you're finding is helpful for those who are working with you?
Nancy, you want to start?
I would start if I had an answer. So I would say that in particular areas, like we are the franchise, for lack of a better word, of Dementia Friends in Pennsylvania. And so when we know that we are addressing a special population, we will do our homework and we will develop those resources, and we will also be inclusive in asking that group, what are your needs and what are your special circumstances? Where are the gaps that you are finding in the system, and where has the system failed you? And build training backwards from what the experience is of the individual who has been left on the sideline by the system. And I think that as foundations, we're uniquely positioned to ask that question of people, not just to ask our grantees, what have you done for people, but to ask consumers or clients, what has been missed? And build services and build training around what has been missed.
I will comment that the first step is just figuring out what people know and don't know and need help in. River Spring Hebrew Home at Riverdale has done a lot of work with SAGE. It has an LGBTQ unit in its long-term care facility, and has I think been on the forefront in training providers. So there are institutions that have recognized this and started their own training, but ultimately I think it's finding the individuals who are who in your area, in your community, who can help you. And I'll also comment, there's a recent article in Journal of American Geriatric Society, again, documenting that long-term care facilities are going to have to educate and train to be prepared for people with HIV. So the geriatric community is beginning to understand this, but it all starts with an institution or a program doing its own needs assessment to try to understand what it needs, and then trying to find the expertise in the area, or looking to a university or some other program that has that expertise to help them.
This is Vince. Early in my career, I was able to work with ACREA, who did the first research in older adults study that came out in 2006. And in San Francisco, that person that we're talking about would be me. And so it's a challenge because ACREA lost funding, and so I think they're down to a staff of one. They are now part of GMHC, but there aren't a lot of people who've attempted to do this. And there aren't a lot of people having this conversation. Just recently, like in the last 3 weeks, we've convened the first, what will hopefully be a statewide planning effort, looking at different areas, rural, urban, what have you, on how this could be done. But there aren't a lot. There isn't a lot happening. That's why today is so exciting for me. Hopefully, saying, hey, we need help, and who can help us?
Since we're talking San Francisco, Meredith Green, who, as you know, is the geriatrician HIV specialist at Golden Compass, has given in-services to long-term care facilities in California, and is always a wonderful resource. I think people are starting to recognize the needs. I mean, I'm going to be going out to Syracuse at the end of the month and just talking to the community and trying to get people to think about these issues. So what I would say is people are starting to recognize they need to get started, and some of this is some of the funding or some of the foundation support can be toward creating the network so people know where to go.
Agreed. Meredith and I work very closely together, and we're constantly talking. And she actually sees people in consultation, even if it's not covered. I mean, she can't do very much of it, but bless her heart. I mean, she does what she can, and our community is really grateful. I think 70% of my network and 50 plus get their care at Ward 86, and many of them see Meredith.
So if I'm to throw it back to the audience who represent agencies or foundations, you've got resources in New York and San Francisco. How do you and obviously in southwestern Pennsylvania here, but how are you going to locally find and support the Meredith Greens of the in your area who can be the resource person and the person to see people are aging with HIV? That's often where it begins.
Well, amazingly enough, that is a question that someone asked almost exactly that way, and so I will make that the last question. And Nancy, do you want to respond to that? So obviously, San Francisco and New York in some ways are unique in terms of both the population that they're serving, but also the resources in those communities that have developed over decades. So what about the rest of the country? Nancy?
We've been very lucky in Pennsylvania, and particularly in southwestern Pennsylvania, where we have had resources. We have academic institutions that have been very involved in this for the length of our work, and certainly before us. So I will tell you that we are a luckier community than most, and the fact that we're doing AIDS-free Pittsburgh and AIDS-free Pennsylvania tells you that we have some leadership and advocacy, and we do have significant state funds that help move this forward. So Pennsylvania is luckier than some other states. But I would suggest to you that one of the things I didn't mention that I think should be a part of this ongoing agenda is there was a little talk about advocacy and involving persons with HIV/AIDS who have traditionally been very, very strong advocates for themselves around HIV/AIDS. It's okay for them to pivot a little and join in some of the advocacy efforts of AARP and others and start to advocate for the needs specifically of HIV elderly persons. Because we hear all the time from our politicians that if they hear it from the consumers, it means more to them than if they just, hear it from organizations or staff people. So I would suggest that whether you're in a small rural community, if we can get past some of the stigma issues, and those are very real, but if we can get past some of the stigma and discrimination issues that do exist for older persons with HIV, I would suggest that there are ways to build advocacy, and I would suggest tapping into existing funding streams versus trying to create new funding streams. And I think that that's one of the benefits of persons with HIV aging is there are a lot of existing aging services funds, and they can assert themselves in there and have their needs be met through existing systems, whether that's food or housing or healthcare, et cetera.
And this is Vince. The National Minority AIDS Council has a program 50 plus healthy and thriving. I'm not sure that's the exact name, but it's kind of designed to create a network of people across the country who are aging with HIV to kind of serve the purpose that Nancy just said. And also there's something called the Reunion Project, which is also kind of similar, a national network of people aging with HIV who are looking to make a difference, who are looking to give back, who are looking to advise.
Well, thank you. At this point, we will turn to each of our panelists and ask them to give their final words of wisdom to the audience. So Vince, let's start with you.
Did you say me, Vince?
Yes, I'm sorry. Yes,
I'm sorry. Well, I'm 58 years old. I've lived with HIV for 32 years, and I've seen a lot in my lifetime. And to me, today's call represents the start of something, hopefully, which will increase the quality of our lives of those of us who are aging with HIV. We might be the only generation that needs this. But to everyone, I just feel grateful, and to grant makers in aging for doing this call today to get this started at this level means so much. Thank you all.
Dr. Siegler?
Again, gratitude for being able to address this audience. We need support and creative ideas at all levels, and from the point of view of a physician, we need ways to connect more effectively with community organizations, so that all of our patients' needs are being met.
Nancy?
So when I take a look at a potential of an HIV and an aging agenda coming together, I look at the factors that we look at for successful grant making or work with a community. And it's around training, it's around the person-centeredness of it all, it's around community-centeredness, reducing duplication, reducing the hassle factor. If we want people to age well within our communities, regardless of the coexisting conditions or comorbidities that they face or the life circumstances that they face, stepping back and looking at things in a real holistic way, and realizing that we're talking about a subset of the population that has HIV/AIDS. We could be talking about a group of the population that has schizophrenia. We could be talking about a group of the population that is homeless. It doesn't matter what the second layer is or the third or fourth layer is. Let's look at the entire person and see the sum total of what they bring to the table and what they need from us as community in order to make them whole, so that overall they have a successful aging experience. To me, that's the goal of putting together HIV, AIDS, and aging, is that successful aging experience for every senior.
Well, thank all of you so much. We want to thank Nancy Zients, Vince Crisosimo, and Dr. Eugenia Siegler for all that you do to make life better for older people and people of all ages. I also want to remind you that Grantmakers in Aging has just released a new publication which has the same title, Aging Positively, Bringing HIV and AIDS into the Aging Services Mainstream, and that's available if you go to our website. It's the top of our materials. I also want to thank the John A. Hartford Foundation for their support of our Conversations with GIA webinar series, and Gilead Sciences for their support of this webinar. We will be making today's slide presentation available to anyone who wishes to view it later free of charge, including both the slides and the audio. Please watch your email in the next few days, and please share this with your audiences and your networks that you work with. And we hope you'll join us for our next conversation, which takes place on Friday, October the 25th, from 2 to 3 p.m. Eastern Time. This webinar is called Policies to Support Caregivers, Opportunities for Philanthropy, and will offer participants an opportunity to learn about the current state of family caregiving policy and efforts to create new and innovative policies across the country. And finally, I want to thank all of you for participating in today's webinar. Have a great day.